Hi, everybody, and welcome to Cancer Coach Live. Today's program is Establishing Goals of Therapy While Managing Myelodysplastic Syndromes. I'm Mikkael Sekeres. I'm Chief of the Division of Hematology and Professor of Medicine at the University of Miami Sylvester Cancer Center. I am thrilled to be joined today by Dr. Hetty Carraway, Vice Chair for Strategy and Enterprise Development, Director of the Leukemia Program, and Associate Professor at Taussig Cancer Center, Cleveland Clinic, and by Ruth Quadra, who will speak about her experience with MDS. We'd also like to hear from you during this program, so please take a moment to ask your questions. Just type them into the box below at any time during the discussion. Please keep in mind that the questions should be general in nature. We are unable to answer questions about your specific case, but we encourage you to bring those questions to your doctor. For your reference, the presentation slides are available for download in the Event Resources section of the player located under the video box. Here are our disclosures. And in today's program, we will talk about the diagnosis, prognosis, and setting treatment goals for MDS. In part 2, we'll talk about treatment and management of MDS. And then in part 3, maintaining your quality of life in partnership with your healthcare team. In this first segment, as I mentioned, we will talk about diagnosis, prognosis, and setting treatment goals. But before we get started, we wanted to actually present you with a poll. What are you most interested in learning about today? A, diagnosis and what to expect. B, treatment and management of MDS. C, how to cope with a rare disease. Or D, resources from the Aplastic Anemia and MDS International Foundation. And I'll give everyone a second to respond to this poll. Sorry, it takes a while for all of these results to come in. It looks like we have a preponderance of people who are curious about treatment and management of MDS. That's coming in at about 80%, followed by how to cope with a rare disease and resources from the Aplastic Anemia and MDS International Foundation. So I'm going to start off by first talking about giving a definition. And this is the same discussion I have with all of my patients when I see them after they've been given an initial diagnosis. We start off with this crazy name for a diagnosis, and that's myelodysplastic syndrome. What does that mean? Well, myeloid cells are bone marrow cells that are dysplastic. They're bad growing. When we look at them under a microscope, they look abnormal compared to other cells in the bone marrow. So the name is quite descriptive of what we see in the bone marrow itself. It's bone marrow cells that are bad growing. Now, the bone marrow is the factory that makes all the cells that wind up in our bloodstream. So blood cells are made in the bone marrow. They come from what are sometimes referred to as stem cells. I sometimes call them grandfather or grandmother cells that give rise to other cells that eventually become the cells that wind up in the bloodstream. So the red blood cells that bring oxygen to our tissues, the white blood cells that help fight infections, that's your immune system, and the platelets that help stop bleeding. I think about it in terms of kids going through school. So we start off with grandfather, grandmother cells. They give rise to other cells, and then they give rise to kindergartners. And those kindergartners go through primary school, secondary school. Eventually, they graduate from high school, and they're kicked out of the bone marrow to make a living. And they make their living in the bloodstream as the red blood cells, the white blood cells, and the platelets. So when somebody has myelodysplastic syndrome, that whole process is essentially broken. If you think about it as a factory, the factory is no longer making the cells that wind up in our bloodstream. And you have a lot of those cells that are stuck at an immature stage. For example, you have a whole bunch of kindergartners running around in your bone marrow. And just as you can't expect kindergartners to be able to work in a factory and make a car we can't expect kindergartners to go out into the bloodstream and perform the functions that they ordinarily would as red cells, white cells, and platelets. So the symptoms of MDS are really reflections of those low blood counts. People who have low red blood cells, who have anemia, because the bone marrow factory isn't making the red blood cells, often have dizziness, they may have pale skin, they may be short of breath, they may be tired, they may have a loss of appetite. The white blood cells fight infections, as I mentioned, so when someone has a low white blood cell count, that person is more prone to developing infections, and those infections can be subtle, like you have an infection on your finger or an infection on your ear, or a urinary tract infection, or they can be more dramatic, a life-threatening infection. And when the platelets are low, the job of the platelets is to help form blood clots and stop bleeding. So too low a platelet count, you're more prone to bleeding. And that can be subtle bleeding. You blow your nose and have some blood on the tissue, or you cough and have a little bit of blood, or more dramatic, where somebody may actually have life-threatening bleeding. So we have another poll here that I'd like to ask. Symptoms of MDS vary depending on which blood cells are affected. What symptoms will a person with a low red blood cell count experience? And the answers are either A, fatigue, B, infection, C, bruising, or D, all of the above. I'll give everyone a second to respond. Wow, we obviously have a really smart group here, and we didn't even prepare you that there would be a test today. Almost everybody describes symptoms of MDS associated with a low red blood cell count as fatigue, and that is absolutely right. And I will tell you from my personal experience, almost all of my patients have some degree of anemia, and their predominating complaint to me is fatigue. And Ruth, I don't know if you feel free to comment on that with your MDS. What was your major symptom?
At the beginning of my diagnosis, which was originally plastic anemia, I had the most severe problems with bruising. My platelets were very low, although I didn't know it until the time that I was diagnosed. So I came to fatigue later as a transplant patient, but my primary experience was with bruising.
Interesting. And I'm imagining, was it bruises? Could you remember having caused all of the bruises, or did they seem to come up almost spontaneously or in weird places?
Even when I was very young, I was always the person in the family who banged into the corner of the cabinet and ended up with a bruise. And I'd had that with me all my life. But near the time of my diagnosis, I had a really severe bruise from banging into play equipment at a niece's birthday party and ended up with a bruise the size of a dinner plate on my thigh. That was a clue something wasn't good.
Yeah. Dr. Caraway, I don't know for you what your most common experiences with your patients.
I would definitely say fatigue. I echo your comments there, Mikkael. It's really been a predominant kind of symptom that so many of our patients struggle with, and it can really challenge their quality of life and independence.
Yeah. Thank you for those insights from both of you. I should say also that we all discussed this at the beginning of the program and agreed to call each other by first name. So from here on out, I will do that. So moving on, the cause of MDS in most cases is unknown. This is frustrating, right? Because the number one question I get from my patients is, what caused my MDS? And everyone can think back to some summer you worked on a golf course or at a summer camp and they sprayed some nasty stuff on the grass, and you wonder if it was that nasty stuff that caused the MDS. But really what happens is, over the course of our lives, our cells that constantly grow and divide and make copies of themselves, over time, eventually they sometimes screw up. And they create a cell that isn't normal, but is able to perpetuate itself and continue to grow. And that's the most common cause of MDS. And frankly, that's why MDS really affects people predominantly in their 60s, 70s, and 80s, because it takes that many decades of living before one of your cells is screwed up and created something that's abnormal. When the cause is unknown, we call it primary MDS. MDS is more common in older adults. As I mentioned, 75% of people with MDS are age 60 or older. I do have a handful of patients who are in their 40s. I've even had people as young in their 30s. It happens, but it's really, really rare. MDS usually does get worse over time. It may progress to acute myeloid leukemia. The statistic here says 30 to 50% of patients. That's really divided. For somebody who has a lower risk MDS, when we say lower risk, that means that they're at a much lower risk of transforming into acute leukemia. Higher risk MDS really has a much higher chance, is closer to that 50% or even higher chance of evolving into acute leukemia. And it's not like it's this dramatic thing where all of a sudden you wake up one day and you feel much, much worse and everything goes south and you have acute leukemia. It's more of a slow slide. So we put this dividing line in that say you have MDS if you have this percentage blasts and you have acute leukemia if you have a higher percentage blasts. But in reality, it's a continuum that evolves over weeks, months, or even years. There are different subtypes of MDS, and the type of MDS depends on many factors, including blood counts, genetic changes, what the cells look like in the bone marrow, and probably most importantly, the percentage of blasts or those kindergarten cells, those immature cells that are in the bone marrow. Rarely, MDS is caused by exposure to chemotherapy or radiation therapy for another condition in the past. So, for example, somebody who has a lymphoma that's treated with chemotherapy and radiation therapy may be at higher risk of developing myelodysplastic syndrome years afterwards. When something like this happens, we call it secondary MDS as opposed to the primary MDS that affects the vast majority of people. So we have a video here. Let's watch a clip of two patients, Joan and Shirley, as they discuss their diagnosis experience.
I was really tired, but I was working. I'm very active. I do a lot of work with women's organizations and community service. And I was the president of the National Council of Negro Women of Orange County, California. So I was telling my sister who lives in Florida, boy, I'm just so tired. She said, well, you need to go see the doctor because you keep complaining about it. So I went and made an appointment. I think it was like the next 2 days. And he said, well, let me take some blood work. He said, have you ever been anemic? And I said, when I was in college, off and on. I said, I don't remember. He said, when's the last time you had some blood work done? And I said, well, been a while. So anyway, he took the blood. And the next day he called me. He said, go to the emergency room right away. Your blood count is at 5.5. And I'm like, what? He says, don't drive, get somebody to take you. I said, okay. So I went and they gave me 3 units of blood. And then they started doing all this special testing, colonoscopy, upper GI, you name it. So I said to myself, being in the hospital about 3 days, I said to the doctor, I think I have cancer. He says, no, all your other vital signs look good. He says, you might have an ulcer, So to make a long story short, for 6 months, I was in and out of the hospital getting blood transfusions. And they were running all these tests on me, continually blood tests and whatever, and colonoscopies, whatever. So anyway, he said, well, we might have to do the bone marrow biopsy. And I'm like, what are you talking about? And he goes, we would have to stick a needle in your hip and draw out some of that marrow just to see what's going on. And then he said, I said, well, I don't like pain. I don't like needles. He said, we can give you a sedative to put you to sleep. So anyway, and on October, Halloween, I was passing out candy for trick-or-treaters. And my doctor called me. It was about 6 o'clock that evening. She was my hematologist at the time. And she said, we finally diagnosed what you have. You have MDS. And I said, multiple sclerosis? She goes, no, Joan, MDS. Go get a pen and write it down. I am at the low, in between the intermediate. So they call my particular type refractory anemia cyberblast, which basically says that I have the cells I'm producing, they come out defective, and they have no longevity. And I have an excess of iron in my blood system.
My diagnosis occurred when I had my annual physical. My wellness exam was interpreted by my doctor. Shirley, I really have some concerns about your blood values. And I think that we need to test your blood more than once a year. So a month later, he called and said, I am going to refer you to a hematologist oncologist. And I said to myself, but wait a minute, that's a cancer doctor. That's not me. But I did a bone marrow biopsy and a diagnosis February 6th, 2012 at 1:30 in the afternoon. You don't really forget those kinds of diagnoses. So that's how I was diagnosed. When I was diagnosed, there weren't the same charts and metrics and distinctions about MDS that we've developed and that have evolved in the last few years. So I was never told if I was low risk, high risk. However, when my MDS transformed into leukemia, obviously I was at high risk.
Those are great stories. I think very telling. Ruth, I wonder if I could ask you if you're comfortable discussing how you were diagnosed. Was there anything in your experience that was similar to what we just heard about from Joan and Shirley?
Yes, there was a lot that was similar in my experience to what Joan and Shirley experienced. I didn't know I was sick. I just went to a well checkup in the year that my father had passed away from non-Hodgkin's lymphoma. I thought, well, I better go just have a checkup, which I put aside while he was ill. And I had a similar call. I got a call from my doctor the day after my blood test, and he said, drop everything, go to the hospital. I'm sending a hematologist to see you. And at that point, my red cell count was 4.3, and my platelets were at 14. They're supposed to be somewhere around 150. So that explained, in part, I learned later why I was bruising so much. So I went to the hospital. I had transfusions right away, and I had a bone marrow biopsy. And the hospital that I was in, which was St. John's of Santa Monica, knew immediately that I had aplastic anemia and said that they couldn't treat me. They sent me to the City of Hope, which is a national medical center for the treatment of these kinds of diseases. And there I was treated for aplastic anemia. I recovered a little bit, but future bone marrow biopsies began to show abnormalities in my bone marrow. And so the diagnosis was switched to MDS. And I was a low-risk patient with refractory anemia, no blasts. And I was treated for that for about a year until I got to my transplant.
Interesting. And that story about initially being given one diagnosis and then that diagnosis being changed, I think is quite common as people go on their journey to eventually receive a diagnosis of myelodysplastic syndrome. Hetty, are these stories, do these resonate with you from what you hear from your patients? Do you typically diagnose patients with MDS, or do they come to you already with an established diagnosis of MDS?
Well, the majority of the patients will come to us after they've been diagnosed with MDS, but there definitely are a handful of patients that come to us with all of the counts being low and us needing to figure out what is the entity that's going on. And, the workup for this can include lots of other diagnoses. So it is important to think about everything that may be contributing to the cells being low.
It's a great point. So what I heard also was the referral to a specialty center for people who have MDS. And I think that's really critical. These are hard diagnoses to make and complicated diseases. And actually, if you look at national databases, how the entire United States tracks cancer, 50% of what's being called MDS is called unclassifiable, meaning that these people may not have even had a bone marrow biopsy, and it may not truly be MDS. It is so critical not only to see a specialist like Dr. Caraway, but also to get specialized pathologists looking at that bone marrow. So speaking of I'm sorry, Dr. Caraway, do you want to say something?
No, I just agree with all of what you said. I think it is important for just that type of analysis, and even potentially a second look at what people have, have been diagnosed with, just to make sure that the picture is comprehensive.
Yeah, we did a study through the National Heart, Lung, and Blood Institute, which is at the NIH, that showed that there was actually disagreement in diagnoses from a local pathologist to somebody who's specialized 25% of the time. So it really is critical to go to a specialty center, at least for a second opinion, to make sure you really have what someone told you that you had. So this naturally gets into our next topic, which is the blood and bone marrow tests that are used to diagnose MDS. We start out with what we call a complete blood count, or sometimes we just refer to it as your counts. And that's really where we're looking at the levels of your white blood cells, your red blood cells, and your platelets, and following that over time, which can give some insight into if somebody's improving to a therapy, or if the blood counts are starting to slip and we need to start a new therapy or a different therapy. We look at what's called a peripheral blood smear, where a pathologist actually looks under a microscope at the different types of cells and their size, shape, and distribution. But the most important, the most critical test we have is a bone marrow biopsy. All along, we've been saying that these cells are manufactured in the bone marrow. That's the factory. Well, then it's incumbent upon us to look in that factory at what the cells actually look like. And that's where we make the diagnosis of MDS. And there are two components to a bone marrow biopsy. One is what's called an aspirate, where we put a needle into the bone marrow and actually suck out some of the liquid components of the bone marrow. And then we actually take a piece of the bone itself. And both of these we look at under a microscope. The second aspect that's really critical is we look at the genetics of those MDS cells. Now, when we talk about genetics in MDS, we're almost never talking about genes that you pass down from parent to child or grandchild. This is not stuff that is running in a family. It's very, very rare for MDS to run in a family. What we're looking at is, when I told you before about how these cells grow and make copies of themselves over decades, and then eventually they screw up, we're looking at the genetics of that screw up. What went wrong in a cell in the bone marrow, not something that's passed on down to kids or grandkids, that led to the MDS actually occurring. So sometimes people with MDS have too many of those kindergarten cells, those immature cells or blasts in the bone marrow. And often the percentage of those kindergarten cells or blasts are what determines what risk category somebody falls into with MDS. So if people have fewer than 5% blasts, almost uniformly they fit into a lower risk MDS category. People who have more than 5% blasts, so between 6 and 19% blasts, often fit into a higher risk MDS category, so they're more likely to evolve to acute leukemia. And then once somebody has 20% blasts, by definition, we say that person has acute leukemia. So you can see why we call it higher risk, because once you've already started to develop excess blasts, you get closer and closer to that 20% number where we would say you have acute leukemia. So treatment itself depends on the risk of developing leukemia or remaining relatively stable with lower risk MDS, as we just said. So, and there are different philosophies for how we treat these different stages of MDS. So for lower risk MDS, sometimes we don't treat it at all. If somebody has relatively preserved blood counts and doesn't have any symptoms, the only thing I'm going to give that person with a treatment for MDS are side effects to the treatment. So for lower risk MDS, our treatment aims are to improve blood counts, reduce the need for transfusions once someone starts to require transfusions, and improve quality of life. For higher risk MDS, we're trying to avoid that transformation to leukemia and help people to live longer. And throughout both of these, we offer supportive care, which can include blood transfusions, treatment with antibiotics, or other things. So we're going to go to another poll. The goal of treatment for MDS depends on your risk of developing leukemia. If the type of MDS you have is considered high risk, what is the goal of your active care? That and the potential answers are A, managing side effects, B, improving blood counts, C, preventing progression, or D, reducing the need for transfusions. I'll give you a second to think about that and answer. And I'm curious, Ruth, you alluded to this earlier. Do you mind sharing what was were you considered to have lower risk MDS at first or higher risk? Or did that change?
Yeah, although my counts were very low, I never had blasts in my bone marrow, so I was considered a low-risk patient. My MDS diagnosis was really based on chromosome abnormalities. And because other treatments weren't available at the time of my diagnosis, which was back in 1996, my choices were really to receive supportive care until my MDS progressed to AML or undergo a bone marrow transplant. Today, I think patients are very fortunate to have an array of treatment options, but the decision-making around which option to choose may be more challenging or nuanced.
Yeah, it's a good point. So our poll, almost uniformly, people voted for C, preventing progression as a goal for treatment of higher risk MDS. That's absolutely right. I would add to it, if you were to say we also manage side effects, improve blood counts, and reduce the need for transfusions with higher grade MDS, I also think that's absolutely correct. So moving along, to our next section, treatment and management of MDS. This will be led by Dr. Caraway. Dr. Caraway?
Thank you so much. I think this is also another really central part of understanding myelodysplastic syndrome. And I look forward to kind of walking through some of the management and treatment options with everybody. Before I do that, I wanted to start with a quick poll and ask, what concerns you most about treatment? A, how well the treatment will work. B, side effects of treatment. C, cost of treatment. And D, how will MDS affect my daily activities? Yeah, so the survey results, thus far really are highlighting, what we care the most about is how well is the treatment going to work that people need to go through. Certainly, there's some of you that are also voting for the side effects, the cost of the therapy. And, for sure, in my experience and listening to my patients, they also really care about how will the treatment for MDS affect their daily activities and their independence. And so thank you for voting. In talking about therapy, as Dr. Sekeres talked about earlier, we talked about low risk and high risk disease. And the risk score really informs the prognosis with regard to whether or not there's going to be concern about transformation to something like acute leukemia or indicates stabilization of disease. It also helps us to make some treatment decisions. And the factors that we walked through that affect the score are the MDS subtype, the number and severity of the counts that are low, whether it's one cell line, like the red blood cell count, or all 3 cell lines, like the white count, the red count, and the platelets. The percent of blasts in the marrow, as Mikkael shared with us, is also very important in terms of risk, as well as the type and number of chromosomal changes. And that's the genetic information that we get from that bone marrow biopsy. And so this piece of information can really be important and is one of the reasons why for many of our patients that are diagnosed with MDS, we spend time teaching and talking about this risk score. With regard to therapy, we're going to walk through a couple of slides about what the treatment options are. And this one really is focused on the treatment of lower risk MDS. And the idea is that, when we talk about active therapy, the idea is that it destroys the cancer cells and helps the body to make healthy blood cells. For some patients that are in a lower risk category, we're trying to get that bone marrow function or the bone marrow factory to make more of the cells since the cell counts are lower. So one way to do that is to use a therapy called growth factor therapy, where it stimulates the growth of healthy cells. And so in the red blood cell situation, we use a drug called erythropoietin stimulating agents, or ESA-based therapy. For white blood cells, we use a therapy called granulocyte macrophage colony stimulating factor, or granulocyte stimulating colony factory. So you hear the abbreviations of GM-CSF or GCSF. And then for platelets, we have a therapy called romiplastin and eltrombopag. So for each of those three cell lines, there's kind of a booster shot that helps those cells kick it up a notch. The other types of therapies that we focus on or talk about are chemotherapy with hypomethylating therapy, and we'll talk more about this type of therapy in the next slide as well. These types of therapies are ones that once they get started, we keep patients on them as long as they're tolerating them and as long as they have manageable toxicities. And these types of therapies can change the DNA in a way that it causes the disease to abate and go away, and really allow the microenvironment in that bone marrow factory to make normal cells. Another type of therapy is immunotherapy. And these are therapies that decrease the immune response that's overstimulated and is causing the cells to be looking funny or developing funny. And so these types of drugs are ATG or cyclosporin, and these are not often used in all patients, but for specific subpopulations, we think about immunotherapy. There are also agents that are immunomodulatory agents like lenalidomide, and these types of therapies are focused more often for patients that have a genetic change called a deletion of chromosome 5. And then finally, we have other options that are targeted therapies. So there can be specific markers or mutations that are harbored on the cancer cells that allow us to use a targeted drug that goes to that specific mutation and really just focuses on the diseased cell and spare the cells that are the normal growing cells. So there's a number of different options that help that we can choose from in patients with lower risk disease. I'm going to turn to higher risk disease. For those patients, we're using more often a more aggressive kind of therapy, and I alluded to this earlier with the hypomethylating therapies or chemotherapy agents. And again, these kind of change the microenvironment in that bone marrow factory so that the cancer cells are driven down and away, and the normal hematopoietic cells or the bone marrow cells can grow and be functional. Other types of therapies for higher risk disease, we talk about a bone marrow transplant. And the reason why is because for patients with higher risk disease, we worry that in a shorter period of time, we worry about that cancer becoming a more aggressive cancer called acute myeloid leukemia. And so for specific populations of patients that are able to go through a transplant, that is one of the mechanisms by which we try to cure MDS. So we'll talk more about that in the upcoming slides. For those patients that are able to undergo transplant, there are times where we need to do an infusion of lymphocytes in the post-transplant setting to better control myelodysplastic syndrome in the case where it may come back despite that patient getting a bone marrow transplant. So we just walked through a lot of different treatment options, and hopefully towards the end, we'll have more time to go through each of those if there are specific questions about those treatment modalities. I wanted to transition into a patient story that helps us talk a little bit more about the goals of treatment and the treatment choices.
Since 2014, I've been taking injections in my stomach area 2 to 3 times a week, the needles. And first of all, I never liked needles. And then they said to me, well, with this new drug, you don't have to take it every 21 days. I took a shot today, and they would teach me how to do it. Now, most patients that take this drug, they have to go in to see their doctor to do it. But for some reason, my doctor felt confident enough that I could do it. I usually have to get blood work transfusions every, I would say, 6 to 7 weeks. Well, fortunately, the last transfusion prior to the one probably coming up in May, it was 3 months. So I went from 6 to 7 weeks to 3 months. And I said, hallelujah. I want to be cured. But I know at this point, there's no magic formula that will cure me. So I do the medication. I'm still looking at other research that's come out, other clinical trials, but sometimes I'm not a candidate for it. No, and I don't get upset about that because right now this seems to be working a little bit better. But I would love for, if I have to have transfusions, if I could just have them maybe twice a year and not, every quarter or, as I say, every 90 days or something like that.
Some of the options that were available to me were, of course, the transplant. And early on, like in the next year, we began to travel around because we sort of thought that we needed a second, third, and fourth opinion on this. And when we went to Moffitt, I was told that a transplant would be one of the best options. And then we went to Cleveland Clinic, got the same thing. Seattle Cancer Care Center, same thing. And so my brother was tested to see if he would be a match. And to our great relief, he was not, both his and my relief. But they did find 4 other people that would be a match. So I always say I was that close to a transplant, but I had real mixed feelings. I had read so much about what it takes to get through a transplant. And I wanted that if that was my only option, but I kept thinking that can't be. When finally the oncologist said, find that clinical trial and get it now, I had the research skills, but I went on clinicaltrials.gov and I was just overwhelmed. I knew what I was supposed to get, what I was looking for, but there was just so much. So I reached out to AAMDS and Lee Clark. I wrote her, I said, Lee, I'm dying. I have a few months to live. You've got to help me. I need a clinical trial. And she wrote back, give me 24 hours. And she sent me, Lee with AAMDS, of course, patient coordinator. She sent me 5 links. And the third one down was Dr. Courtney DiNardo at MD Anderson in Houston. And I applied. She accepted me as a patient after 1 million tests. And on December 26, 2015 at 1:30 in the afternoon, I took my first 2 blue pills. And those blue pills are chemo pills, and I've been taking them ever since, every morning. And all of my blood values are normal.
Those are great. I think there's a lot from Shirley has discussed. Ruth, I wonder if you'd feel comfortable talking about the kind of treatment you received and what your goals were at the time.
My treatment was bone marrow transplant at the time. This was 1998 when I had my transplant. And so bone marrow was the thing. It was kind of before stem cell transplants were really as common as they are now. So my treatment involved radiation, chemotherapy, and then the infusion of donor bone marrow. When we were first searching for a donor, my brother and sister were tested, and they matched each other, but not me. And I was very fortunate that the coordinator at the City of Hope found a donor for me in the National Marrow Registry, which is now called Be the Match. It was an excellent match, better than probably my brother or sister would have been. And like one of the videos said, they were relieved not to have the burden of being my donor. Because if things had gone south for me, they would have felt bad for the rest of their lives. So there's that part to consider. So I had an unrelated donor transplant on October 6, 1998. I'm now 22 and a half years out of my treatment. But at the time, we really didn't have a choice. I was only 43. My husband and I had 2 young teenagers at home. And so the thought of waiting for leukemia and imagining what that treatment would be versus the bone marrow transplant, it was really a pretty easy decision for us to go straight to transplant. I had family to help take care of the children. The hospital was not far from our home. And I went into the hospital thinking, I'm just going to do this and I'll be home. It ended up being 44 days, which is not bad. Wasn't bad at the time, but now it seems like, how did I ever do it? And it was really just one day at a time. Mostly I felt exhausted, frustrated a little bit that I couldn't go home sooner, but everything came to pass in its correct order. And by the time I got home, I just had some sleeping to do and some recovery. Not to minimize any of the things that happened in the process, but looking back, I remember mostly we decided to do this because it was really the only choice, and we did it, and we came out on the bright side of things.
It's wonderful. Dr. Carroll, we've heard the burden patients experience with transfusion. How do you manage that? How does that change?
Yeah, I think that's a really great question. And Ruth, thank you so much for sharing your story with us. You know, I think as we heard about in the patient stories, these types of decisions are not easy. When do you start therapy? When do you change therapy? How do you make these decisions? And then even when you have lots of transfusions, how do you manage that? I alluded to these stimulating factors, the growth factors earlier, like ESA-based therapy. And more recently in the last year, we've had a newer agent, luspatercept, that's been approved for patients with anemia, although it's a special subpopulation of patients that have to have ring sideroblasts and for some patients also a mutation called SF3B1. So we do have newer agents that are coming out that are now FDA approved and even being studied for patients that may not have these ring sideroblasts or mutations like SF3B1. And so we'll talk more about this in the upcoming slides and I'm sure throughout the program, but the clinical trials for these novel agents are also helping us to find newer agents for patients diagnosed with MDS. And I loved hearing the story earlier where there was a clinical trial that patients were considering. So those are definitely parts of the treatment algorithm and questions that you should be asking your physician as you think about next steps. I'm going to keep going if that's okay, Mikkael?
Yes, absolutely. Please do.
You know, as we heard about, you know, there's a lot of considerations that go into the decision to go to transplant, not the least of which is, you know, will this therapy work and how well will this therapy work? And we talked about that being a key indicator as one of the key questions for patients as they think about what therapy to choose and why to choose those therapies. In the discussion of bone marrow transplant, we highlight the fact that bone marrow transplant is only the only potential cure currently for myelodysplastic syndrome. And, you know, as we talked about earlier, not all patients will be eligible for a bone marrow transplant. Some of the comorbidities like a higher age or overall health can really make us think twice about the risk-benefit ratio to consider a bone marrow transplant. There are also disease stage and treatment options. So if the MDS is not well controlled and close to becoming an acute leukemia, that would not be the time to launch into a bone marrow transplant as an option. And also looking for an adequate donor is important. And if patients don't have a good donor, that can also limit the ability for bone marrow transplant, or at least have a real discussion about what the risk is if that donor is not a full match and what the considerations are for that scenario. When we talk about the type of bone marrow transplant for patients with MDS, we talk about an allogeneic bone marrow transplant or a hematopoietic stem cell transplant, you'll hear these same words. And it really is that in that bone marrow factory, we're taking the damaged or dysplastic cells away and replacing them with healthy ones from a donor. And in order to do that, there's a conditioning regimen of chemotherapy that's given to patients to get rid of those abnormal cells. And then the donor cells are infused, much like a blood transfusion or a platelet transfusion. This procedure, of course, is associated with fatigue. You heard from Ruth that she was tired. Patients can have weakness. They are certainly at higher risk for infection, so that's taken seriously and patients are monitored closely. And of course, there's always a risk of bleeding when the counts are low, as well as a risk of chronic graft versus host disease, where the transplanted cells can identify the normal body as foreign and start to attack it in the liver or even in the gut, or even in the skin or other places. So those are all things that patients are monitored for that undergo a bone marrow transplant. The other things that are important when we think about the options with regard to transplant or otherwise is that supportive care really relieves the symptoms of MDS and the side effects of treatment. So as we talked about, patients can have shortness of breath, they can have dizziness, fatigue, and transfusions can really help to mitigate those symptoms. And for some patients over time, after a long period of time, patients may feel like they're no longer benefiting from those same transfusions. Infections due to white count being low can also be mitigated by preventative antibiotics, or even for some patients thinking about vaccinations when appropriate. Bruising, we heard a lot about from Ruth, was one of the things that she was experiencing. Patients can have nosebleeds, gum bleeding, and so really struggling with that. Sometimes we need to use things like platelet transfusions to support our patients through those types of symptoms. And then there can be treatment for other physical and emotional side effects of treatment. Patients can feel down and depressed because of the loss of independence or just not feeling like they could do the things that they used to be able to do. So being able to address the holistic needs of each and every patient is really important. And your team should help address each and every one of those pieces. Ultimately, the goal of supportive care is to improve your quality of life and to remove discomfort. So there's another polling question here that I wanted to kind of wrap things up with. Allogeneic bone marrow transplant is the only potential cure for MDS, but not every patient will be eligible for it. Among the factors that need to be considered are A, the country in which you live, B, age and disease stage, C, comorbidities, D, A and B, and E, B, and C. This is not meant to be a trick question. All right, so the majority of you got this absolutely correct. Answer B and C. As we think about bone marrow transplant, age and disease stage, as we talked about, and comorbidities are really things that we need to be mindful of with regard to making decisions around transplant. And finally, I wanted to just highlight that clinical trials help to identify new ways to treat rare diseases like MDS. This is a really important point. I think importantly, everyone should look for clinical trials and really understand what the options are for you as you think about next steps in the treatment of MDS. These clinical trials are well-controlled research studies that evaluate the safety and efficacy of drugs with strong potential for treatment success. It takes a lot for a clinical trial to even open. There's a lot of thought that goes into why these drugs are being studied for specific populations. And so if you have MDS, consider taking part in a clinical trial to advance your treatment and the treatment for others. The diversity in clinical trials is important to ensure that drugs are effective for the broader community of MDS. So we want all kinds of patients to enroll in studies. And again, it's important to ask your doctor about open clinical trials that treat patients with your specific MDS subtype. Not all patients will be eligible for all studies. And so part of that is because of the focused research question that may be going on. But you don't know unless you ask. So with that, I'm going to transition back over to you, Mikkael, to talk about the next section, maintain your quality of life in partnership with your healthcare team.
Wonderful, thank you. I'm so sorry. Let's watch, let me just get oriented here. Okay, sorry about that. So, you and your doctor will work together as a team to monitor your progress as you make treatment decisions and address symptoms. And I always say to my patients that we have a partnership and we're going to make these decisions together. And sometimes those decisions are not going to be made on the spot. I actually encourage my patients, as we discuss something, to go home, sit across a kitchen table with a family member and talk about what's occurred and what the next steps should be, and then come back to me. Most of the time, these decisions are not urgent and we can take time to reflect on them. Side effects of MDS treatment can affect your quality of life. And I always say, if the side effects of treatment are higher than the side effects of what one of my patients is suffering from MDS, I often decide to not give any treatment at all, particularly if somebody has lower risk MDS. If you do develop symptoms, talk to your doctor right away about how to treat and manage them. Some of them may be related to MDS, some not, because a lot of my patients have other medical conditions as well. And learn about the side effects of different treatments so you can know what to look for. Some treatments, like our traditional chemotherapy, can cause nausea, vomiting, loss of appetite. We've actually become much, much better at managing those with traditional chemotherapy. And a lot of the therapies we offer for MDS aren't traditional chemotherapy and don't involve the same side effects you may have seen with friends or family members who've undergone treatment for cancer. And as Dr. Caraway discussed, bone marrow transplants can have a variety of side effects that are going to be reviewed in a lot of detail before you decide to embark on a procedure like that. So I'm a big fan of shared decision-making. Like I say, I think it's a partnership with your healthcare team. When you decide to start treatment, you and your doctor will review results of your tests and the rationale for starting treatment, your treatment options and how they fit with your goals for treatment. And I think that's one of the most important things that we do when we talk with patients, is try to establish what those goals of therapy are, because the goals that I might take on for treatment may not be the same as the goals of a patient of mine who's 20 years older than me may decide to embark on. You should review the benefits and risks of each treatment, how that treatment will impact your quality of life and how you function, and particularly if you have the supports at home, if it is going to impact your quality of life and if someone is going to be able to help you. I always, always, always encourage my patients to consider a clinical trial, particularly with lower risk MDS. I look at this as something that we're going to be tackling together for years to come. And I want to try to organize the therapies that we're going to be using over those years. If a clinical trial is available now, I still have the same therapies that are available on the market that I can offer my patients years from now. So I always encourage them to consider the clinical trial first. It doesn't nullify the other treatments that are already on the market. And then write down your questions when you go to speak to a doctor or a nurse or a member of your healthcare team. When I go to a doctor, everything flies out of my head. So I like to write things down when I'm much calmer and haven't walked through doors that say cancer center on it, which I think causes almost immediate amnesia for questions that I may have developed. So now I apologize. Now we're going to look at one more clip of Joan and Shirley discussing how they work with their healthcare teams and what their coping strategies are.
At the very beginning, I used to get a lot of bone aches. My bones were aching. And I called them and they said, well, that's because the medication is working. It's stimulating the marrow and so don't be concerned. And I used to get some back aches also from it. And they said, well, that's all a part of it. Your body's getting used to this, So I said, okay. And then they said at the beginning, be careful where you go, you have a compromised immune system. I'll be honest, it was me. You know, my support group that I meet with every other month, we've had doctors that come in there, and there's one doctor, I won't say his name, but he's another confidant. Anytime I need to talk to him, and he's a specialist in San Diego. So I kind of create my own team.
I feel I always had the very highest quality of medical help from whomever I would meet with first, just to take vitals, to the next to talk about the questions, and then finally when the doctor would come in, I felt that I had exceptionally good experiences. Now, maybe all of them are that way, because if you do treat this kind of cancer, you are a pretty special person. But I never really had anyone sit down and say, you may expect this. What I did have is reading all of the research online. Like I said, I had many, many volumes of clinical trials and transplants and people that have actually passed away, and their relatives had talked on the blog about the last days. All of that I was so fortunate I didn't experience. But again, maybe my faith, which was very, very strong, and my music, and my spouse, who was a wonderful caregiver, and this wonderful group, this team of medical people, plus AAMDS, all of these people came together to help me through it. And I'm so grateful for all of them. If I had any advice to give others, I would say, no one is going to be an advocate for you except you yourself. And with all of the information available now, it's up to you. You've got to sit down and do the work. And there's resources available. You've got to reach out to those resources, and you've got to talk to other people. There are people that have been through what you're going through and will share all of their experiences and offer you encouragement and offer you suggestions of next steps. And then you have to make out that list every time you go to the doctor, well before you get there, all those questions that you give to the person that is just before the doctor. Give that list to the person and say, will you please present these to the doctor so that we can have a good discussion? And if you do the work and you make those very critical, important research files, so you can go back and look at something on paper, print them out, and then seek out that help, you will find a lot of help. It's all around you.
Thank you. That was I thought really moving, actually. I wonder, Ruth, could you tell us briefly about what worked well with you and your healthcare team, and what advice you would give to other people who have MDS about coping strategies and finding support? And then we're going to jump into some questions.
The main thing that helped us, my husband was my caregiver, and for me, keeping our friends and family apprised of my progress was his main method of coping. It gave him an outlet. He let everyone know the latest information, which prevented him from having to be inundated by phone calls or feeling like he had to respond to individual emails. Later, the history that was preserved in his emails gave us both a chance to digest what we had been through. But I can't emphasize enough the importance of the items that we saw on a previous slide under partnership. My husband kept a notebook of my test results, the questions we had for the doctor, her answers, and plus the details about all of my medications and their schedules and so forth. There's so much to learn about MDS, a lot of which will come to you from the AAMDS International Foundation. There's so much going on at each appointment. I think it's really critical to take someone with you to your visits, with a second person listening and perhaps taking notes. You have someone to talk over everything with afterwards.
Really, really nice advice. And I want to emphasize that the Aplastic Anemia and MDS Foundation have a fabulous toolkit and resources to help learn about MDS and help guide your thinking and what questions that you might want to ask. So please visit them online or give them a call. I want to start with one question that we got and that is, one person asks, if I'm ineligible for a transplant, is treatment lifelong? Dr. Caraway, I wonder if you could address that.
Yeah, certainly. I think as you alluded to, it's very important for patients and for physicians to identify are patients at a lower risk or at a higher risk disease with regard to MDS. And there are patients that are ineligible for transplant, but if they're in the lower risk category, then a transplant wouldn't really be indicated in the majority of the time in that scenario. And so, yes, the treatment would be lifelong in the sense of the variation of treatments could be supportive care to other modalities. And we don't expect that MDS would go away on its own. It can be supported. And for all patients that are having symptoms, those would be things that we want to talk about. When do we start therapies to help decrease those symptoms and make those decisions together?
Yeah. I'm going to ask you to go over, I know we're at time right now, but I feel bad. There are so many great questions that have been asked. I want to try to address a couple of other ones. One person asks, is active care better than supportive care? How do I know which one I'm receiving?
Yeah, I love this question because, we wrestle with the therapies and, it really is, what are the therapeutic options for a patient? And is there data to show that starting those therapies earlier will actually impact their goals? It may be that patients want to only decrease their symptoms, but it may be that they also want to have cure of their MDS. So again, it really is a focus on what the goals of therapy are. For the lower risk MDS patients, I would highlight the fact that starting therapy earlier we don't have data that show that those patients are going to live longer just because we've started therapy earlier. I don't know how you frame that for your patients, but I think making decisions about optimal quality of life, staying active, staying independent, those tend to be the things that my patients really care deeply about. And so making those decisions for every person, it's a conversation that you need to embrace and really be honest about kind of the risks and the benefits of starting on therapy. For many of our patients, it means once you start, you stay on therapy as long as you're tolerating it and the toxicities are manageable and patients are doing well.
Yeah, I love how you said that. One phrase I've heard before is that sometimes no therapy is the best therapy. You don't have to start treatment, particularly with lower risk MDS. I'll ask one final question before we wrap it up. Why do therapies like Vidasa quit working after a while?
Yeah, I wish, that's if we knew the answer to this question, Mikkael, right? Like if we could get these drugs to stay working forever so that we could keep this disease under control and not have patients go through transplant or cure this disease in different ways. We do believe that ultimately these cancer cells outsmart the drugs, and somehow they find a survival mechanism. Despite the therapy that we give, the chemotherapy, they find a way to avoid the impact of that therapy. And how it does that, there's a number of different mechanisms that we believe to come into play. And, we're thinking about ways to mitigate that resistance pathway that those cancer cells have so that we can have durable responses to those approaches that are longer and better for patients. But that is the million-dollar question, not just for drugs like azacitidine or decitabine, but for many of the chemotherapies that we give for patients with all different kinds of cancers.
Yeah. Yes, very frustrating for all of us, but we're working on trying to figure out mechanisms to keep these drugs working for longer. So I want to thank you, Hetty, and thank you, Ruth. I always learn so much from both of you for joining us today and giving us informative discussion and facts about this very challenging diagnosis. Thank you to our audience for joining us for this special patient education program. I'd also like to thank the Aplastic Anemia and MDS International Foundation for their partnership on this program. Support for this program was provided by Bristol Myers Squibb, Millennium Pharmaceuticals, Novartis, and Taiho. Please remember to complete the questions at the end of the program to help reinforce some of the topics we covered today and receive a participation certificate. As a reminder, please see the event resources section of the player located under the video box to download today's presentation slides. This program will be available on demand on Cancer Coach Live. I am Mikkael Sekeres, and I'd like to thank you again for joining us.